Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert. I'm here today with Dr. Millicent Rovelo. How are you doing, Millicent?
I'm doing great. How are you?
I'm great. We have a great guest today.
We do.
This is a very special podcast.
It's very special, and we are very excited to have her. We are excited to have Dr. Vinaya Rednam, all the way from Houston, coming in and joining us on the podcast.
Thank you guys so much for having me.
Of course. How are you?
I'm doing fabulous.
Great.
It's great to have you. And from Houston, Texas.
Yes.
It's a little bit better weather here, I hope.
It is absolutely 1,000% better.
You got out of the pressure cooker of,
Yes.
of Houston. The humidity's tough this time of year.
It is. It's very difficult.
Well, we're happy to have you.
Yes, very happy to have you. And so you have some specialties that you do that we are very excited to talk to you about. But let's get to know you a little bit better. So why don't you just tell us a little bit about where you grew up, where you did your training, and sort of how you landed where you are now?
Yeah, so I'm a Midwest girl. I grew up in St. Louis, spent most of my life there. And then I did my college and med school at the University of Missouri in Columbia. So I'm a Mizzou girl. We're SEC now, but we weren't when I was there. We were Big 12. And then I did integrated residency for plastic surgery at University of Kentucky. And then I did an aesthetic fellowship in the University of Florida. So I just kept moving further and further south as I kept training because I really don't like the cold weather.
Until you landed in Houston.
Until I landed in Houston, and I was like, cold sounds great. But then I went straight out of fellowship to my first job, which has become my forever job. So I've been in Houston now for 10 years. I joined somebody who was established in practice, and we kind of rebranded in 2019, and now we have 11 surgeons. So
Wow.
so my group's called My Houston Surgeons, and so it's really exciting. I love what we built.
That's huge.
So from 2 surgeons to 11 surgeons.
I was the third one that joined.
Okay.
So, yeah.
And this is all plastic surgeons.
We're all plastics except 2 ENT and then 1 facial plastics.
Got it. Okay. And so tell me a little bit about your practice. What do you like doing? What do you enjoy doing? What's your bread and butter there?
So I have a kind of interesting practice. I call us, we're privatemics. So I actually do a lot of post-weight loss, body contouring, facial surgery. That's my passion. I love that. But I also am a microsurgeon, and so I do a lot of free flaps, largely microfacial deeps, and that's kind of what my group does together quite a bit.
We don't do that.
We do not.
I want to just go on record for all those of you who are thinking, like, I wonder if we don't do that. We try not to do that.
So it's a weird, it's a weird but interesting mix, and I like being able to do that. So, but I would probably say that's about 30% of my practice is breast reconstruction, and then the rest I do is mainly cosmetic surgery. But like I said, my passion is really my post weight loss patients, and that just kind of grew. It just and with how things are now, it has become a huge part of my practice.
Right. So, yeah, we were talking about that earlier. We have, obviously, post-bariatric, which is surgery for weight loss, and that's been around for quite some time. But over the past few years, we've had all of these GLP-1, the weight loss drugs, and so a lot more people are losing significant amounts of weight, especially with Mounjaro. I have patients losing over 100, 150 pounds. And so they're basically like a bariatric patient, and they have a lot of weight loss and a lot of skin.
Yeah, I mean, there's one thing that I want to talk about that just very quickly. For those of you who are, losing weight and having surgery, especially with medical weight loss and with bariatrics too, sometimes the nutritional issues that come up with the surgery can be very significant. And that's why I think people that specialize in this, like you two ladies do, and I'm going to take myself off that table for that. I don't do this anymore. I used to. I trained in Pittsburgh where we had
There's
There's a lot. I mean, I think Dennis Hurwitz kind of updated all of Ted Lockwood's procedures, and I was there as he was doing that. So I did a lot of it when I started out, but you have to kind of be focused on this. And obviously with my nose and face kind of stuff in my complex breast, I'm just not doing these operations because you have to be doing them all the time. So.
Well, it's like anything. You do a lot of rhinoplasties. I don't do any rhinoplasty. And it's because you don't want to dabble in these things.
No.
You want to really, I think it's amazing as plastic surgeons that we are trained to do everything, but at some point you do have to narrow if you really want to become an expert in that area.
Yeah, I gave up rhinoplasties my first year and a half.
It took you about 6 months.
Yeah, and I was like, yep.
I made it to a year, and then I was like, no, not for me.
Not my thing. I'm going to give them to this guy. So, yeah, 100%. I think if you don't do it a lot and it's not your thing, you probably shouldn't be doing them at all, is my.
So how do you approach it with, there are obviously around the country, there's a lot of people that are losing weight and they are left with skin, and they're left with sometimes medical issues from the skin, sometimes just that they don't like it. It's hard to exercise. There are functional issues. There's aesthetic issues. How do you approach the patient that comes in and says, well, I've lost 150 pounds and I got skin all over the place? Where do you even begin with that patient?
So for me, a big part of it is not, like you said, nutritional, but I also put a big focus on mental health. I think that all of our patients need that, but especially with my weight loss patients, I really want to know their motivations. Nothing.
I think a lot of us need the mental health. too.
A lot of us.
It's just in general, like it's good to have good mental health when you're doing any of this work,
Exactly,
for sure.
exactly. And, I really focus on what they want because, I can look at anybody who's lost 200 pounds and I could list off a laundry list of things I want to do, but it's really what they want to do. So we spend a lot of time just talking. We're not doing exams yet, things. We just talk about what their goals are and what they want because not everybody wants everything. And I really kind of focus on that, and then we start kind of listing an order of what's most important to them and making game plans from there because a lot of these patients may be my patients for years and years and years because we are not doing everything at once for safety reasons.
No, you can't. It's just too much.
Age and health and what is their nutritional status because just because you lost 200 pounds depends on how you lost it and what your nutritional status will be. So I feel like there's quite a bit of workup, more so than maybe my average mommy makeover for what we have to do before we're ready to be like, okay, let's make a plan for surgery.
Yeah, and in general, we don't sit there with a patient who's, say, having a mommy makeover, which is, like some sort of breast operation for rejuvenation and then a abdominoplasty or some liposuction or all the above. We don't look at those patients and say, boy, we better, check the albumin. We better see how their metabolism's working. We don't. That doesn't come up a lot of times for plastic surgeons. However, when you've had massive weight loss and it's been done with some sort of medical or surgical intervention, there can be a lot of anarchy with the nutritional status that causes wound healing problems. And we always talk about minimally invasive surgery. Well, the thing we're talking about here today is maximally invasive. We're talking about
as maximal as you can get.
The biggest incisions you can make on a human body are made by people doing weight loss surgery.
In
any specialty.
Yeah.
So, and to heal those wounds is not trivial.
And protein can be an issue. There can be iron absorption issues, and that's also why it's so important what the method of weight loss was because we have to focus on that. And it's hard. I think it's hard because people can sometimes mentally be like so ready. They want these surgeries, but they're not physically there yet. And it's really important because the last thing we want is a huge incision to break down, and then now we put somebody in a worse position.
Yeah.
Yeah, wound vacs are not fun.
No.
I've seen a few of them on some weight loss patients that are just like,
and I find
that's
too
gonna
that
take
like
a while.
I think we've gotten to a point for the most part where our post-surgical weight loss patients in general are usually followed pretty closely by the bariatric surgeons, and they have a nutritionist on board before they even start. But I think it's the medical weight loss patients, which are getting their medicine from telehealth or online from some pharmacy.
From who knows where,
and those are the ones that are actually making me more nervous than the surgery ones because you don't really know if they even have a doctor and who's following them. I had one patient who had lost 150 pounds on some medication. And on the table in the OR, she just smelled like ketones. Like her body was just breaking down fat, like in real time as we were.
Like in front of your face.
Like in front of my face. I'm like, that smells like ketones. Like she was just depleted and she was getting her care through a telehealth doctor who was not looking at her, who was not actually seeing that she was quite small. So I think that you're 100% correct. That whole talk and workup before you even get to the surgeries is super critical.
And even afterwards, when you've been through all the mental health with a bariatric surgeon, even if you're doing the medical weight loss through a proper clinic, they're preparing you for what surgery might be afterwards. There's support groups. There's all these things. But if you're just doing the medical weight loss and not really through a monitored way, then you become really depressed when you now have to think about having these big scars and changes contour when that wasn't really something they'd ever really prepared for.
And they say that all the time. Like, nobody told me that I was going to have all of this skin. Like, they just in their minds think, I'm going to lose weight, I'm going to look great. And they don't realize that, well, actually, if you want to look as good as you want to, you're going to need all this skin removed, and that's surgery.
Yeah.
Yeah, the skin thing is real too. And just for our listeners, the skin not only looks, extra wind sails that you can sail to Catalina with. Yeah, that's not helpful, but there can be medical issues with it. You can get infections, especially in skin folds around under your belly skin, called paniculitis. You can get problems with functional issues. You can have problems with exercise. All those things that come up, and patients really don't know that. They're not really instructed. Like, by the way, like when this is over and you get down to the 175-pound goal weight, you're going to need $150,000 of operations.
Yeah.
That's hard to understand.
That's a big one.
That insurance may or may not be involved in, and I don't know what's the climate like in Houston.
It's difficult to get things covered, and I think it's become more difficult over the years. I feel like when I first was in practice, I could get things covered much more easily. And the hard part too is you have people that will say, "We'll do tummy tucks through insurance," though a tummy tuck is never covered by insurance. It becomes like very confusing to the patient when they're like, "But I thought my friend got that covered." And generally paniculectomy might be covered or breast reduction, but that's about it. We've had people even with like all the documentation and things like that for other procedures, and they can't get it covered.
Yeah, and the parts they cover are usually very minimal. And if what you really want is to look amazing and great, that's usually a couple of extra cosmetic add-ons and procedures to make that wow factor as the after result. And you're not going to get that with the basic surgeries that insurance covers. So if you really want that great surgery, you're going to have to fork up some money out of pocket for sure.
And there's times where I'll do combination because I'm in network with a lot of things with reconstruction. So I don't mind if somebody has that real medical support and documentation, but a lot of people don't. Yeah. And there's just a lot of upsetness about it because they aren't prepared for it. They really aren't.
And it's not cheap.
No,
no.
Here in Beverly Hills, it's bananas. I don't know how it is in
Houston's still a pretty saturated market. So, and that's the thing is, it depends. You can get cheap surgery, but it might look like cheap surgery.
And these are big surgeries. I mean, these are big surgery. I can't say that enough. And that just means a lot of time in the OR. Yeah. It means that you're paying an OR fee and you're paying an anesthesia fee for a long surgery. And these are not, you might have had your bariatric surgery and it was 45 minutes and you have these tiny incisions. This is not that. So you're paying for a big deal surgery and you're paying for an expert. And that's not cheap.
And the hard thing we see in Texas especially is, Mexico's very close by. Mm-hmm. We all know a lot of people are going to Turkey now too. But specifically for these surgeries where wound breakdown is going to happen if you have enough incisions somewhere along there. And
100%.
Now you're flying out someplace and nobody wants to take care of you when you get back. Mm-hmm. So it's not worth trying to save that money to go outside of the country. It's just not specifically for these type of procedures.
Right.
Yeah, I think Ernie Manders was one of the guys who taught me a lot about bariatric surgery when I was at Pittsburgh, and he would just say, the complication rate in these big operations is 100%. Something will happen that needs to be cared for by this team of surgeons that you're looking at, and it's a wound breakdown, some type of infection, something that needs to be revised, something that's not right. There's a contour irregularity. Like he said, there is fat necrosis. There's going to be complications when you're moving this much tissue around with incisions that are literally the size of your body. It's going to happen. So if you go to someplace across the world and if you come see me and say like, first of all, you won't get in and say, oh, I had, a circumferential body lift in Mexico. Can I see Dr. Calvert? My answer would be, get back in the car, drive back to Mexico, and see the surgeon that did this because they're the best one to take care of you. I didn't do it. I don't know what was done. I don't know what they used. I don't have any business trying to take care of you because it's like boxing with one arm tied behind your back. It's not going to go well. And patients do not get this. They don't consider it. I did a Tyra Banks episode about it back in the day, and it's just like, you don't want to get into the situation where you have no one to take care of you.
Yeah.
Yeah, that's scary.
And that happens. I don't know what's your policy if somebody calls the office.
It's generally that. And we'll even get people like, can I come in and get my drain removed? Things like that.
No.
And it's like, it's just become so difficult that because then what happens? Something else is going to happen.
Right.
And you keep calling me. And again, I don't know exactly what's happened.
No, and you didn't get paid to take care of these people. So like, what is the deal? Like, no, you can't come. I mean, just, for those of you listening, I'm sorry. Like, you have to understand as surgeons, we'll take care of the patients that we operate on. We're not willing to jump in, on the cacophony of problems that comes up from these operations that we have no business, knowing even what happened. We didn't know, did they use a mesh? Did they use some kind of device? Did they use sutures that are even like we don't know anything about your operation. So how is it that we can possibly jump in and take care of you? It's not a good idea.
And I really try to explain to patients, like, we're not just removing things, we're changing blood supply. And that's the big problem here is if you could just take off things and everything's the same, but we're changing that blood supply so much, we can't guarantee how things, even when they're in our hands, are going to go. Right. So let alone somebody flying out there, and I have no idea what their workup is and what they're doing for you.
Well, we told a little story on our last podcast about some Turkish interventions that were happening, so you have to stay tuned for that. Yeah. There's some stuff that goes on in these other countries too that like we don't know. We don't know. So we think they should go. If you're in Houston, here's your doc. If you're out here, we think you should go to Dr. Rovelo, not me, and not it, and get people that are real experts because that's what it takes to do these operations well, and you have to plan for them. I mean, they are expensive. How you're going to finance this stuff. It's not cheap. And we always sit here talking about plastic surgery as though everybody, can sign up and do it tomorrow. That is not the case. You have to really, financially, if I had to get plastic surgery, I have to think about the finances myself. Yeah. It's not inexpensive.
And it's maybe a bad analogy, but I always say, like, you don't go buy a car and then not expect to do maintenance on it. And it's the same idea. You're putting a big investment into it, and there might be a hiccup or something might happen. You have to be prepared. If you've put every last penny into that, then it's just not the right time for you.
It's not the right time.
No, you have to be prepared to know that things can happen and that you have to take care of those things. And that's very real, and that's why there are all these consent forms, and we have all these discussions with people. So I'm sure you have a robust process for that in your practice, especially if you're doing a lot of this.
Yeah. I mean, we get people from all over. And, if you're coming from out of town, you have to stay for a long time. You have to stay for a long time. You have to, follow up the same way you would if you were in town. So, I mean, we do make it as safe as we can if you're going to come from somewhere else.
That might be a little earthquake for you.
Okay.
You're here now.
Like, is anyone else feeling this shit?
Yes. That's a welcome to Los Angeles earthquake.
We're just for you. Yeah, it's still going.
Well, I think that's my first earthquake.
Well, there you go. See, good thing you were here.
Yeah.
You get a little taste of the LA.
Something new.
So I will tell a quick story about that. I was doing a revision rhinoplasty in the Roxbury OR, and there was a 5.5 Richter earthquake, and the building outside my window across the street, 450 Roxbury, was doing the hula out. It was like, it looked like it was swaying back and forth. And I jumped on my patient, held on to her, and everything was fine. But I had a PA student who was like rotating with me, like observing. He sprinted out of the building and was never seen again. And he wasn't from California, so he like freaked, and he was just like, and he never came back. He's like, I'm going home.
You're like, we have a patient on the table.
I was like, it's not a big deal, dude. It's California. Like, this stuff happens here. So
that's funny.
So there you go. There's your first earthquake.
Yeah.
So I have a question for you because this comes up a lot with my practice. I'm curious to see how you approach this. What do you do with the patient that still needs to lose a lot of weight? Or it's a patient that's borderline. You're like, I could do your surgery. You definitely have a lot of extra skin because you've already lost 100 pounds. Ideally, you lose another 50 or so. What do? Do you tell them to lose weight? Do you tell them that we're just going to go to surgery and it might not be the best surgery? Mm-hmm. Like, what's your approach to that?
Well, I kind of talk with them about like what their weight loss process has been, right? It's because sometimes it's just they're like, I've done everything, I'm stalled, I'm not going anywhere. If they have a bariatric surgeon and they haven't seen them in a long time, I'll usually have them go back and talk with them more. But again, we had a lot of people who've had gone to Mexico and had their bariatric surgery, never really followed up with anybody. If that's the case and they don't really have anybody to talk to, that's when we'll actually offer medical weight loss for them. I don't do that just for anybody, but if you are somebody who's serious about surgery and you want help, then we will supervise you having some undergoing medical weight loss with us. I think that, I want them to be as close as possible, and I hate to say no to somebody, but I also know how they're going to feel when their results aren't great.
Right.
And so generally, if it's 50 pounds, I'm going to tell them no, but I'm not turning them away. I'm going to help them with it.
But what if they're like, yeah, doc, sounds good, but I'm never going to lose that weight. So can we just do something now?
I guess if they're in a healthy weight range, they're overall healthy themselves, and they feel comfortable, because definitely in Houston, I see a lot of people who are happy being heavier. They're healthy, then I'm okay with it. It's all about the expectations. I'm a big wish picture person. So show me some pictures of what you're hoping to achieve. And if that picture does not match what I'm seeing, then I'm just going to say I'm not the right person for them.
Right. Yeah, we
Well,
What do you do?
There's a BMI of 38 and up paper that's brewing with Dr. Rovelo over here, and I mean she's showed some results in
do you have a
Paris.
I don't have a cutoff per se. So for me, it's really just where they carry their weight. Yes, of course, they have to be healthy and they have to be at their goal, whatever their goal is.
Yeah.
If they tell me they want to lose 50 more pounds, I say, well, then lose that weight first, because obviously you don't want to lose it afterwards. But if they're like, I'm really not going anywhere, and they're still, BMI of 35, 36, I look to see what surgery we're doing and where they're carrying their weight. And a lot of times, you're doing a tummy tuck, maybe they're carrying it all in their legs, so it doesn't really matter.
Yeah.
But maybe they're carrying it all in their belly, and I'll say, well, we can do a staged liposuction procedure and skinny you down so that there's less fat in the area that we're working with. I think I've had like 2 people sign up for that.
Yeah.
Most of the time they're like, yeah, I don't want to do
They want to do it one time.
So I say, it's going to take 3 extra hours. It's going to cost you a lot more money. Your recovery is going to be a lot harder, and you're definitely going to have more complications, but we can do it. And I'll just spend an extra 3 hours doing the liposuction, and then we'll go on to the surgery. And you know what? They do okay.
Yeah.
They do okay. The results, they're not going to be great.
Yeah.
And they have to know that the results are not going to be aesthetically optimal. But we can definitely get them through safely, a well-chosen patient.
I think I'm always expected California to have most people in LA have a lower cutoff. So
We have pockets.
Yeah.
We have pockets of LA, for sure.
Well, yeah, I mean,
Yeah.
so my patients are all for whatever reason, I get all these skinny people. I don't know why. I get every fitness model that needs their breasts redone.
Yeah.
But Dr. Rovelo here, she has a practice, hospital-based practice that is different from the Beverly Hills practice by leaps and bounds, and she does cases there that are just, I mean, they're mind-blowing, quite honestly.
Yeah.
And she
But
gets
they're
them.
in a hospital. That's the thing.
Yeah.
So if I had a similar patient here in my practice here in Beverly Hills, I'd be a little more hesitant to do that because it's not a hospital. And so there's not going to be anybody monitoring them postoperatively as closely as the hospital would monitor them that first day. So if I have someone that really I'm worried about, I will send them either to Cedars or to my other offices just to make sure that they're safe.
Most of my patients are in the 35 to 40. See,
there you go.
Yeah, I
All
feel pretty comfortable with that.
Yeah, it's just what it is.
Yeah.
So do you have a favorite procedure? So when we're talking about weight loss procedures, we could literally do surgeries from head to toe.
Yeah.
You have the face, the neck, the arms, the breasts, the back, the tummy, the thighs, the knees. You could literally do surgery on all
Head
of
to toe.
them.
Yeah.
What is your favorite to do?
Okay, my 2 favorite are body lifts and brachioplasties.
Body lifts being lower body, upper body?
I'd say a lower body.
Lower body.
Like a circumferential
Yeah,
kind of deal?
circumferential, but a fleur-de-lis body lift. That is that lower body lift. I think it's just because they're so dramatic. They're dramatic,
And if you're doing 35 to 40 BMI, they need it.
Yeah, exactly.
They need all of those incisions.
And I feel like, I've gotten down to where I get really consistent, nice vertical scars. And so because of that, I'm like, I feel pretty comfortable. Okay, let's throw that out there because I can really get your waistline what you want it to be.
Right.
And I find when they are at that level and they have that much horizontal and vertical laxity, they don't care. They're like, they want the
the skin
slimmest
gone.
look they can do.
Yeah. So you're talking about the fleur-de-lis, which obviously, as we know, is when you do a typical tummy tuck incision at the bottom of the abdomen, sometimes all the way around if it's a body lift. But you're also adding a vertical scar from the sternum all the way down to the pubic bone. So you get this inverted T incision pattern. It's not for everybody.
No,
but
it's definitely not for everybody.
If you need it because you have a lot of skin, then you need it. Because if you just were to take the skin in the up and down direction and do that horizontal incision at the bottom, they would look great. They would have a flat abdomen. They look good in a faja and clothes and garments. But when they bend over or when you start playing with the skin, there's a lot of loose skin left. And the only way you're going to get it out of the midline is to make that incision and really snatch them in.
Right, because I always tell people there's different vectors of where our skin is loose, and if I don't pull you in both those vectors, we're not going to get that result. And so I leave it up to them. I've had a few people who decide not to do it, and then they come back back later, and we can always then do that component of it. So it's not like you burn the bridge if you don't, but obviously most people don't want to have to come back and have that again.
Right.
But I like it. I think it's a good tool to have there because I can still leave the rest of the scars really low. I'm not a big fan of the old school, have that scar like right around the belly button that high to just so you avoid the vertical. I'm like, well, it's so high.
It's so gross.
Yeah.
No, that's not cute. But like the thing you want, a lot of these patients are not trying to go out and be bikini models. And obviously you have a vertical scar that's going to be visible. But the whole point of that lower scar is to be aesthetically pretty as well. I'm not a fan of the straight across scar. I think that's the ugliest scar you can do because it's so unanatomic. But if you can get a nice curve to that lower abdominal incision, it just makes it look better. It's just following what your eye wants to see, sort of that dip down in the center.
Exactly. And I think that, if you're following those aesthetic lines, it looks nicer. And so you're trading a contour for, a hidden scar. Yeah. But most people, that vertical, unless they have really bad hyperpigmentation, with all the tools we have now, you can really get a nice looking scar.
Yeah, absolutely.
Now, I want to change gears a little bit because, a lot of the information that, we bring to our patients it's hard to communicate in a very short 15-minute or 30-minute visit. And you said that you did start a podcast about a year ago. So how has that been working for your interaction with your patients? What's the name of your podcast, first of all?
It's called the Confidence Doc Podcast. So that's kind of what I go by as the Confidence Doc, because at some point I was like, what do I really do? Because I do reconstruction, I do this, and I'm like, I bring confidence to people.
Nice.
And so it's kind of where I went with it. And when I started about a year ago, and when I started it, I was like, I'm just going to talk about different plastic surgery things. I wasn't planning necessarily to have guests. And then before I knew it, I'm like, well, I wanted people to learn about everything. So I have had medical architects on. I've had people who do fashion. I've had anesthesiologists. I've had everybody who's basically involved with things that make us feel better. But it's been really great because I feel like I've reached my patients in a whole new way. You can now just turn it on when you're waiting for an appointment while you're driving home. And it's given them a glimpse into things on a much bigger basis than I could do on a 2-minute reel on Instagram. But at the same time, it's conversational. I don't have scripts. I just talk. And it's been really fun for me to even learn about new things from other doctors and other people as well.
Yeah, the podcast. So, we obviously been doing this for a long time, so we've found that our patients get a lot of, they get sort of the insider information that they may or may not get to in a visit. So I think that it's great that you're doing that. I'm sure that your patients appreciate hearing your point of view and how you see their operations. Do you do it where you say like, oh, before you come into the appointment, take a listen to this podcast?
Yeah, absolutely. Yeah. I think I do that with everything. I'm like, go to my social media channels, go to this, because I feel like by that time you have people, and I'm sure you guys have this all the time, come in and they're like, I feel like I already know you.
Yes.
And, I post my family a lot too, and they'll be like, oh, how are the kids' birthdays? And, if sometimes I'm almost a little taken back because I'm like, oh, wow, people really listen and watch these things. But it's great because then we can really kind of come in and just really talk about the procedure. We don't have to break the ice. The ice is already broken. We already know each other.
Right. And they have a baseline understanding of what you're talking about.
Yeah.
So there's always going to be questions and things you can go into in detail, but at least they're not coming in completely blind to what they're going to expect and what they're going to get from a surgery standpoint.
Yeah.
Which is helpful.
Yeah, I find that patients sort of hang on every word that we say if they're letting us operate on them because they really want to see, like, how do you think about this? I've, especially in my world of, facial aesthetic surgery with revision rhinoplasty, primary rhinoplasty, facelifts, the patients are so concerned that they're not going to get what they want. And so they do hang on every word. And I think that the same is true for body contouring procedures, especially these big ones where they're making, pretty significant financial and time investment. The money will come and go for people, but the time that you put into it, you want to get it right so that if they can know who their doctor is, it makes a very big difference to them.
Yeah.
But with a lot of these surgeries, we make long-term relationships.
Oh, yes.
I get to know them. I get to know their spouses, their families. I might operate on all of those people. So
True.
it's like, it's nice that they have this extra connection with me, and they know that, like, who I am on the podcast, who I am when they see me at work, or even it's all the same person.
Right. And you're going to take care of them because they trust you and they know you and you're invested in them. They're invested in you. And so I think with this focus that you have on bariatrics, and clearly you do a lot of these weight loss patients, where do you see this specialty going? Like, what's on the horizon?
Gosh, I think that it's going to continue to evolve. I know you guys had done an episode on Kris Jenner's facelift, right? Recently, that I listened to, and talking about how that people are surprised by it, but that's the standard. Facelifts should be that great that everybody looks that good, but that's not the case, right?
Well, it should be.
Well, the ones that you notice.
It should be. Well, I think that's where post weight loss needs to go as well. I think it's lagged a lot behind. I think that we've gotten very used to this skin removal term, which I get it. It's easy to say that, but it's so much more. If you have really good post-weight loss body contouring facial work, you may not ever look like you never had it, but you can look pretty amazing. And I think I want the bar to be set higher. And I'm starting to see that more. Unfortunately, I think there's still a lot of people who are just kind of chop it off and you're good. Be happy. It's not there anymore. And I don't think that's the case. I think there's a whole nother level we can provide. And I want to be one of the people doing that.
Well, it's the same thing, sort of the trend, I don't even want to call it a trend because it should just be the case, that we started seeing, 10, 15 years ago with aesthetic breast reconstruction, right? Mm-hmm. Like back in the day, it was like, oh, just put in some implants or just put a flap up there. There's something to fill out their bra. They'll be happy. They'll be fine.
Yeah.
But then as we had more people going into the world of aesthetics and bringing aesthetics more into that reconstruction space, the plastic surgeons were like, no, that's not fine. Like, why can't we also make these reconstructed breasts beautiful as well and bring all of our aesthetic principles to the reconstruction? So I think we are seeing that more with the bariatrics because we're all doing so much of it. And so we're bringing this aesthetic knowledge that we have from our tummy tucks, from our breast lifts, our mastopexies, the use of all the fun tools that we have in the aesthetic space. We're now bringing to the bariatrics as well.
Well, with the facelifts, I have like a vendetta against the tuft assassins, the people that cut off the sideburns on all these ladies and make these incisions up their foreheads and cut away their sideburns they look like they're trying to go for some futuristic mohawk or something. And I think it's awful. And to see people, still doing that makes me just cringe. And it's like, why can't you just find a way to preserve the normal hairline instead of, distorting it and making it bizarre? But yet, that's kind of when you say, like, we see these bad facelifts. Well, those are the ones that you see. You don't see the good ones because you can't tell. You can't tell that they had a facelift, and you can't tell that they just look better and they look great and they have the confidence from, having the amazing work. And I think that is the direction for plastic surgery in general, is to think it through. Just think it through a little more. Make a better plan. These incisions that you have to make to take away the skin, they're almost unavoidable. But can you do it in a way that you minimize tension and that you place it in an aesthetically hidden way, and that when they're walking, it's not seen by the rest of the world like that? Those are sort of the things that I think are on the horizon for these body contouring operations.
100%. And I love it. Like, if I post something and someone's like, well, could you close up? I can't see the scar. I'm like, that's the point. That's the point.
Yeah.
If I just zoom in and have them turn their leg out for that thigh lift, then I didn't do that great a job. If you can't really see it from all these angles,
that's the point.
Yeah.
That's the point.
Yeah.
And I tend to post my befores and afters of my body lifts and stuff with no garments on, because it's so easy to hide an ugly scar in someone's underwear. So I want people to see it. Like, yes, it's great that you can hide the scar in the underwear. That's great. But I think patients also need to know that there is going to be a scar. You're never going to get rid of it completely. You can get it as fine line and thin and near invisible, but there's always going to be a scar.
Yeah.
And I think that these patients really need to know that you're never going to have a scar go away completely. So I think I like to show my scars. I'm like, that's what it's going to look like.
I just took a video of my facelift scar yesterday in the office, and I said, let me take a video of this. She said, but you can't even see it. I go, that's the point. That's why I want to take a video of it, because it's where I put it. You can't see it. She's like, I didn't even know how you did this. Like, I was trying to figure it out. And I was like, well, it's because it's behind the tragus and it's hidden in this crease. And then I did it into the sideburn so that the hair grew over it and through it. And she's just like, yeah, my friends are like, you didn't have a facelift. Where's the scar? And then I show behind the ear and they can see it there because it's in the crease. But you don't want to see the scars. That's the whole point. The point is to really have artistry. And artistry in plastic surgery comes from your evaluation and assessment and planning. And I don't think that that's really well understood, even by some plastic surgeons, that you win the battle of a great result at the examination and planning part of the consultation. It's not won in the operating room. By the time you're in the OR, it's like by the time the first shot is fired, you've either won the war or lost it already based on your plan. And that's the same with plastic surgery. You have to have a good plan. You have to know how you're going to get it done.
And that's where the artistic side, I think, what we do comes in. I do a lot of design type things, and you still, even if it's clothing or jewelry, you still have to start at the beginning. Otherwise, if you just start working with your materials, you're wasting things. You don't know what your outcome's going to be. You want someone who's sat there and done all those planning steps, so then it looks easy because you've done all those things.
Right. Yeah, you make it look
100%.
easy, but there was a lot of thought
Yeah.
that went into it. Totally.
So, in terms of your breast reductions, which is an operation I think that is oftentimes really neglected in terms of artistry, tell us a little bit about your approach to breast reduction as a medical procedure. Do you like to use the superior pedicle? Do you like the inferior pedicle? And this is, we're going to get in the weeds a little bit, people, but like, what's sort of your approach to get a breast reduction to look great afterwards?
So I'll tell you, when I trained on an inferior pedicle, and I haven't done a single.
Everybody
And
did,
so
yeah.
everybody
Every
did.
resident.
And I don't do any inferior pedicles now. I hate how they look. I like a superior medial pedicle, sometimes a medial pedicle, just depending. But I feel like I can get better shaping with that. I remember too, when I was first out, I would commit to everything. I commit to so little now. I mark out kind of my basic points, but I do a lot on the table. I feel like why would I base everything on the lower part of the breast that's hanging? I'm going to end up with a terrible shape. So I'm big on like subtract what you need to subtract. And if you really want it for shaping, you can always do addition, subtraction, which I think works much better. But yeah, I'm for long-term shaping. I don't like to force. If you force things on the table, it's not going to last. So to me, it's just basic geometry with how I'm moving things around, but I like everything based superiorly as much as possible.
Yeah, I mean, that's kind of our thing. I mean, superior pedicle, and just for the listeners, when you do a breast reduction, you can base the blood supply to the nipple either in the top part of the breast, the bottom part of the breast, the middle part. You can do the lateral part, whatever you want, but you have to have some way that you're thinking about keeping the nipple areolar complex alive. It's the blood supply to the nipple that's important. Unless you're going to do a free nipple graft, which, there are some breasts that you're going to do that on if they're, super long and super large. But for the most part, you're doing something to make it look beautiful. And I always thought that if you leave the superior medial part, which is the upper pole and the cleavage part, that's the part you want.
Yeah.
Instead of cutting that away and leaving the bottom heavy lower part, you're going to get a better looking breast. And there were many of the surgeons in Pittsburgh that liked that, but the bulk did do inferior pedicle. That's what we trained on. And now I can't even think of a time I've done an inferior pedicle since I was probably a senior resident, which was a long time ago.
I mean, it's actually even more, not just that, it's more efficient. Inferior pedicle took forever.
Yeah, it takes a little bit longer.
Took forever to do it. And I was just like, and now I'm just
easy.
like, if you have a pretty straightforward breast reduction doing superior medial pedicle, it can be a pretty efficient surgery and get beautiful results.
Yeah, I think I did one by myself in Newport Beach in an hour and 45 minutes, and the tech was sort of like, Doc, how did that just happen? Like, these take forever. And I was like, they don't. You just have to kind of, you have to know where you're going.
Caveat: Newport Beach breast reduction is
How
like
big was that breast reduction?
maybe it
my
was 50
small,
cc.
my extra small. Like, oh, how cute.
Maybe it was 50 cc. No, it was probably like 300
Can I ask y'all, do you use drains in your breast reductions or not?
So I never did. I don't think you need to because you just don't need to. I will use it occasionally if I'm putting mesh in. So if I'm doing a breast reduction with mesh, I'll do a central pedicle actually and put mesh at the bottom. And I will leave a drain in those, although I'm moving to not, because I don't think you need to, but I'm just right now kind of feeling out if I'm going to leave the drain or not. But if I'm not putting mesh in, absolutely not. There's no need for it. I don't think.
I'm not a big drain fan for breast reductions. But if there's a component of lymphedema, which there often is in some of these breast reduction patients where the breast is so heavy that there's a fluid, like you, as you're doing the reduction, you're seeing the sort of the lymph.
Yeah.
Then I'll put a drain just for a day or two if necessary, but it's pretty rare.
Yeah.
I don't think you need to use drains for a reduction. I think you put it back together, get good hemostasis, and
There's no dead space.
No.
yeah, I mean
Yeah.
it all collapses in
Yeah.
on itself, and I do pillar sutures, so everything is closed up.
Yeah.
That's really the bottom line, is that and we did a whole podcast, Don't Fear the Drains. So it's not really a big deal if you do use drains.
Yeah.
For those of you who use drains out there, we're
Yeah.
we're not drain shaming you. But at the same time, we're just saying we don't use them. All right? So, you figure it out.
I'm in that boat too. I think I've reduced the amount of drains I used over the years.
Yeah.
I don't use them in arms. I don't use them in breasts. It just, if there's no dead space, like there's
Yeah, if
no
you're
empty
closing
space,
it
then
up.
there's
Yeah.
no reason. Yeah.
Yeah, and I close down dead space in the nose now. I mean, this was, for a long time, thick skin noses were just so hard to deal with. And there was a lecture, I think, again, but probably before electricity, by Ron Gruber, R.I.P. He was one of my professors, and is up in the San Francisco area. And he showed putting sutures from the skin to the underlying framework, where he had all kinds of necrosis and problems. He said, you can't do this. Well, I do it routinely now, and a lot of us do. And when you close that dead space down, you can manage thick skin noses. And it's kind of like you can't be a slave to dogma. If you're in plastic surgery and you're not sitting there asking yourself, why do I do this? Why am I putting a drain? Why am I closing these pillars? Why am I not closing the pillars? Why am I using this pedicle? If you're not asking those questions as you're operating, if you're not getting better intraoperatively while you're doing this stuff, then you're not doing your patients a service. You want to be advancing yourself and advancing your craft and getting better and making the specialty better so that the patients get the benefit. And I think we did a lot of things, even 10 years ago that we don't do today. And it changes rapidly. Plastic surgery changes, I think every 6 months we could update a lot of these topics. They really evolve.
Yeah.
I mean, without a doubt, especially in the cities that we're in Los Angeles, Houston, Dallas, New York, Miami, it's flying, and you have to be in the game to understand that.
Yeah, I'm always suspicious of surgeons that just really aren't in the game, as you say. They doing the same thing since they came out of training. They don't keep up with conferences or going and learning new techniques or staying on top of things. Because it's it moves so fast. Even since the time I've been out of training, things have changed so much.
Oh,
so
yeah.
I think that you really want to go to someone who is staying in that educational world and making sure that they're on top of what's happening out there, because it changes really quickly.
Yeah, there's no surgeon far enough out that isn't have something still to learn.
Yes.
we all do. Until you retire, we all have something
You
to
can
learn.
always
Yeah.
be better. You can
Yeah.
always do something better.
Well, I like your term privatedemics. I mean, that's basically, we have a fellowship, and we have the USC residents, and I have a visitor every, from countries I've never heard of half the time. But, there's always somebody in the OR who's looking to learn. You have 11 surgeons. Do you guys have a fellowship?
We do get fellows from University of Texas.
You do?
Yeah.
Okay. And they rotate with you guys and
Yep.
do all that? Yeah. So,
But what's the fellowship based?
So it's largely for the microsurgery.
Okay.
Yeah.
Got
you
it.
have enough surgeons. You guys can have
We
your
do.
own. You could have your own
We could.
fellowship.
It's in the works. It's in the works.
Yeah, I mean, it's not easy. We
No.
have 2 fellows a year.
Yeah.
And I think there was about nine of us, basically, and
It's a
soon to
lot.
be 10. We're adding somebody in on the body contouring part pretty soon. We're hopeful. But yeah, I mean, being able to teach other plastic, when we get these young plastic surgeons fresh out of residency, they're doing whatever the updated, latest techniques are. And so they bring that sort of into our practice, and we hear, this is what so-and-so is doing, and this is what we talked about at this meeting. And so for us, I mean, it's great. And then we have the USC residents that come through, and we train them, and they all have their own cases. Everyone's like, oh, do they do your operations? Just to be clear, they do not do our operations. We do our operations. They actually, the USC residents have their own cases. The fellows have their own cases, and then we are in the OR with them doing those cases. And the education is tremendous. And I think in those settings is where you're going to find the most enlightened and progressive and forward-thinking surgeons. When you're training people, they are all over you.
Yeah,
So
it's
look to
very
hear it.
dynamic. kind
Yeah,
of
and it's
interaction.
great.
Well,
And I
it's
think
fun. I mean, even when we have like college students who come and they're interested in a medical career, it's fun. You like realize how much you love what you do when you have somebody young who's just really interested and wants to know everything about it.
Yeah. Well, Dr. Rednam, is there anything else that we haven't talked on and about your practice and your philosophy that you'd like to elaborate on?
No, actually, I feel like I've got to chat about a little bit of everything I love doing. So I think the only thing I would tell you is that one thing that you would also ask me about what I really want to see in the future is I want to see every practice putting emphasis on the nutrition and mental health care. I think that needs to be a standard of care everywhere, and I think that it will help us take better care of our patients.
Yeah, that wouldn't be a bad idea if everyone out there was focused on that. But it's hard.
It is hard.
It's really hard to get that holistic approach, but I think it is so helpful. I mean, other specialties with bariatrics does it. You can't have a bariatric surgery unless you've spoken to the nutritionist and had a therapy appointment and done all of these other check marks. I mean, plastic surgery probably shouldn't be any different.
Correct.
Yeah, I mean, it's. I actually, when I was doing, the revision rhinoplasty, I first started into it, which now I do a ton of it and I do it all the time. I just thought so many of the patients had PTSD. I just thought my patients they were traumatized by their bad rhinoplasties in a way that it was, and
It's very real.
it is,
Yeah.
and there have been books written about that by Mark Costantian about the revision patient and the trauma that they've gone through, and they get the rhinoplasty, it doesn't work for them. And I thought about, like, should I have a psychologist that's somehow on staff or totally affiliated? And it's very tricky. It's very hard to do that. But I think in terms of your interaction with patients from a mental health standpoint, we should all have. And I have several questions on my intake form, let alone what I ask them in the exam room about their ability to do that. And everyone's like, you shouldn't operate on people that are on, antidepressants. I said, well, I wouldn't have any
That's a
patients.
lot of people.
Yeah.
That's pretty much
That's
like
a
it's
lot
in the
of people.
water.
Yeah.
I mean, come on. I mean, I wouldn't have any patients. But the reality is that you do have to assess that, and it's a very important point that you're making. And I applaud you for including that in your focus with your patients.
Well, the way that I kind of got around it is actually work with a group. So I have all my patients have a mental health assessment. They have a nutritionist that gets a virtual person who gets assigned to them, and that works through the whole process with them. So it was something my sister is a therapist, and so I was like, I need you to help me with this assessment form. And then before I knew it, I got introduced to some people, and then I was like, wait a second, you guys are trying to create what I need. And so it's a whole virtual platform that I get to use now with that. So I think that might be the solution eventually, is that maybe we can't all have a full-time therapist in the office, but maybe their services will be able to use to do things like that.
Yeah,
That sounds great.
I
I
think
like that.
it's something I'm gonna put in my pipe and smoke right now and figure that out, because I mean it's really tough. I mean, we try to do it a lot, for our patients, and I have an incredible staff, and literally everybody on my staff can talk my patients off the ledge when they're like seeing the swollen rhinoplasty. I mean, the facelift patients tend to do really great. The primary rhinoplasty patients tend to do great. For me, it's the revision rhinoplasty patients that are very, very challenging, because they all experience, and for those revision patients that are listening right now, I mean, they experience the trauma that they had over as soon as they have another operation. And I tell them they're going to do that. Like I said, this is going to happen. You're going to have this, and you're going to feel like you've had a bad nose job all over again.
Yeah.
Even though the splint's on, you can't see it, and you're going to feel like, what did I do? This is a mistake, because it's the reaction of of what happened with the trauma, and that's a big sandwich to eat, when you're trying to go through a revision operation.
And none of us like seeing that. None of us like seeing people that we're trying to take care of suffer.
No, of course not. No,
yeah.
I mean, that's the whole point. But they do get through it, and with the prep, it helps. But having somebody that could kind of jump in, I'm sure My assistant Caroline is listening right now. What's that
happy to
number?
talk to you guys about
Who do we talk to? What telehealth? That's happening. Like, oh yeah, because and for
It would
the
be
most
helpful.
part,
Yeah.
it would be
It'd
great.
be very helpful.
Well, cool. Well, we really thank you for coming in and
Thank
coming
you
out
for
from
having
Houston.
me. This is
This
great.
was so fun, and it's really exciting. We'll have to come visit you in Houston.
I would love that.
Yes.
I would
This
love that.
massive 11-person practice. That's huge.
And growing. We hope to keep growing. So.
Oh, that's good.
That'd be
That's
great.
great. I mean, Houston's a great medical city. It's just sweltering hot, and I'm pretty sure that
Surface of the sun.
I'm pretty sure the national bird is the mosquito. There is that true? I think it is.
I live with the forest behind me, so yeah.
Oh my
it
gosh.
is.
I mean, the mosquito bites I got there were just crazy. I mean, I think they've sucked like a pint of blood out of me.
Winter makes it worthwhile.
Yeah, winter's great.
We'll come visit you in winter.
Well, cool. Well, thank you so much.
Thank you
for
guys so
coming
much for
in.
having me.
Well, this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.